I am working today, 2 days after Christmas, to just see patients and make sure that I'm not missing anything. It's a little bit on the sadder sense since most of the people are, off during the holiday season, but I'm still working today. I think this is the part of medicine that a lot of people don't see. People see the glamour part of it, but just have to understand that there are some, I don't want to call it risk, but there are some downfalls when it comes to medicine, especially with the choice of field that you want to go in medicine. I'm a cardiologist and my wife is an OBGYN, and she has a few cases today. She has one case tomorrow. So, there's a lot of good that we do in medicine, but there's also some things that we have to give up, and a lot of times it's our time and our freedom. It can be stressful, especially during the holiday season, because we want to be at home with our families. We want to be able to celebrate the year with our families, but this is just one of those days and weeks where we just happen to be working in the hospital, unfortunately, but not too sad, because I was able to spend Tuesday, Wednesday, and Thursday with them, and I'll see them again this weekend. So today is a half day for me. So what I'll be doing is seeing patients for about less than half of the day, most of the morning. I have, let me see, 1, 2, 3, 4, 5, 6 patients to see. One of them is a phone call, just follow up on blood pressure. The majority of them is just seeing how they're doing. One of them is a brand new one, so I'll be interested to see what the reason for the hospital consult is. Let me just go ahead and look it up right now. The reason they're coming to see me is computer slow. Computer's really slow, dear goodness. Coronary artery disease. So they probably had a CT scan. More than likely they had a CT scan that showed some plaque in the arteries. CT scan for something like, maybe they have a history of smoking, or they just had a CT scan in general, but they're coming to see me for it. So doing my due diligence. The biggest thing I'm going to be looking for is any symptoms that they have. If they have symptoms, then we may want to pursue something like a stress test. But if they have things, don't have any symptoms, but they have a strong family history, then we want to look at other things. Maybe getting an echocardiogram, an ultrasound of the heart, maybe even doing a stress test, maybe looking at, I wouldn't do calcium score for this, just because we already know that they have plaque or calcium around the artery, so it may be a redundant test. So 6 patients overall to see. One of them is a phone call, and one of them is a brand new patient. So it does get exciting, more exciting because it is a half day. So I have the later half of the day after around 12, 1 o'clock to get the house ready for the kids, and maybe get a workout in. I was supposed to work out yesterday, but I didn't. I just didn't. But I've worked out 2 days this week, working out. Hopefully another 2 to 3 more days to make it 4 to 5 days each week, which is more than enough for me. But in addition to seeing patients, one of the things I'll be also doing is reading echocardiograms, which are ultrasounds of the heart. This week I'm not the echo reader, so usually I am just reading echoes that I ordered or my team ordered, being my physician assistant. So I was just looking to see if I have any echoes to read, and I have one, so I can just go ahead and read that one right now. The reason that it was ordered was for someone who had mitral valve disease. Their mitral valve was probably not closing appropriately. It was either prolapsing, which led to a regurg. More than likely it was regurging. If it was a mitral valve prolapse, typically we don't. Oh my goodness. This has not been recording. Oh, it is recording. I got super scared. I thought this was not recording at all because I didn't see the numbers, but it's teeny tiny. But the reason that this individual got this was likely for mitral valve regurgitation. So they've had the mitral valve repaired, and basically we're making sure that everything is flowing appropriately. The last thing we want is for it to be repaired, and then it needs some type of intervention in the future. Once they've had it repaired, there's criteria that we look at to make sure that the repair was successful. So far, that criteria seems to be met. Seems to be met. So I'm going to finish reading this one, but once the patients start showing up, we'll talk more about what I've seen and how I'm going to treat them. So I'll be back probably in about 2.5 hours. So I still have some catching up to do, still have some notes to write, still have some phone calls to answer, and labs to sign off on. All right, so right now I've finished notes. I've finished reading the echocardiogram. I had just one, thankfully, for mitral valve regurgitation. So individual underwent surgical repair of the mitral valve, and the valve is working appropriately. So we'll do our routine follow-ups to make sure everything is going well. And typically we just leave it alone unless they're having symptoms that are new, that are different from what they've been used to. So they're having shortness of breath, then we check that out. If they're having chest pain, we check it out, and they're doing well. So right now, more or less just finishing answering some notes, reading echoes that were read, making sure that the patients have been informed about it, and they receive notification about it through a letter, through a phone call. All right, so this is an example of an echocardiogram. This is the ultrasound of the heart. Right now it's looking at a 2-chamber, looking at the left atrium and the left ventricle. This is the ventricle, the bottom part, and this is the atrium, the top part of the heart. I'm going to be going over a few of these over time, but this one just looks at how well the heart is contracting, and then in the next view it'll show if there's any regurgitation or any blood that's going in the wrong direction. Right now everything is moving exactly how we want it to. My schedule for 2025 is already going to be crazy. 1 second. So I mean, like, this is just my inpatient and outpatient schedule. The pink is when I'm on call for the hospital, more than normal, but that means that that means that February I don't have any call days. So the good thing is I have options of, if I need to swap, I can swap out in February and not have any concerns about conflicting schedules, since my February schedule is a little bit more a lot easier. I'm debating on keeping it how it is, just having a harder January, knowing that February and March will be a little bit lighter. There's a lot of different ways you can approach it. It does look crazy though, and I do feel like I may regret it, but for the time being I'm going to keep it as it is. Looking at my schedule, not counting, well, no, you gotta count it. Counting New Year's Day, I have 1, 2, 3, 4, 7 days off. So that's a lot. That is 23 days, 24 days of straight working. So not straight working, but 24 days of work. It does seem crazy. So I may look and ask some friends to see if they're willing to swap a weekend and do that weekend in February. If not, power through it and just understand that my February is going to be a lot easier. All right, I have finished all my notes, but I left some stuff at home, and thankfully I still have about an hour before my first patient shows up. And also, thankfully, I live about 6-minute drive from my workplace. So I'm gonna head home and, oh, don't lose me. Don't lose me. Got me back. Hopefully. Yeah, there we go. So it got me back. So I live pretty close to where I work, so I'm gonna just head home and get the items that I was looking for. Like I said, I have about 5 patients that are coming in the office. One of them is brand new, and my 6th patient is going to be a phone, a televisit. I think the biggest concern is due to blood pressure. Blood pressures have been on the lower end, and we have stopped all medications. So the question is, what do we need to do in the future? And I think the answer is just going to be continuing to hold the blood pressure medications and improving hydration, making sure that his source of liquids have a little bit of electrolytes in it too. I anticipate he's not drinking as much because he's not been feeling well, so something that has enough electrolytes in it, maybe a little bit of salt to help improve that blood pressure. From what I last recall, the blood pressures were in the high 90s, which aren't too terrible if you're not having any symptoms, but with people who have high blood pressure, you can imagine that if their blood pressure was in the 160s or 140s or higher, and now it's in the 90s, they're not going to feel too well, especially if it acutely went from 140s down to 90s. They're going to feel lightheaded and dizzy, but if they've slowly decreased it over time, then their body is able to adjust a lot better with it. So I'm just going to see how he's doing. I think his blood pressure actually has been slowly declining or decreasing over time, and we were able to fortunately remove some of his medications, but now it looks like even with all medications removed, he's still having symptoms, so more or less trying to figure out what else can be causing it. Is he losing blood in his stool or in his urine and things like that? So I got about 40 minutes until my first patient comes in, so I'll run a few more errands before then. All right, so I got what I needed to get from the office, from my office at home, but I still got about another 30 minutes, and I've pretty much done everything that I needed to do until my first patient comes and sees me. One of the things I want to stress the importance of for people who are considering medicine is, number one, make sure you're getting into medicine for the right reasons, because if you choose it just for money, if you choose it just for, the name of a doctor, but you truly don't have a passion for being a doctor, it's going to be one of your biggest regrets that you'll ever make. I've had a lot of my friends who have quit medicine because they initially went into it for the wrong reasons, or another one, I've had a lot of people who go into it for the wrong reasons and they keep on changing jobs. Time to time, they're finding a new job every 1 to 3 years. So make sure that, number one, you're getting into medicine for the right reasons. Number two, when you're choosing your job, that's going to be just as important, because not all jobs are created equally. For example, I was a hospital medicine doctor in New Jersey. I would say if I had to choose between being a hospital medicine doctor in New Jersey versus the one at my local hospital, I would probably prefer the one in the local hospital, being that I trained there as a resident, but also it's just different. I like it a lot better, and I'll kind of just leave it at that. But when you finish your training to become a doctor, be very, very careful, be very picky regarding your first job, but also know that your first job doesn't have to be your only job. But if you choose the right first job, it will be your last job. It will be your first and only job. For instance, in cardiology, I was extremely picky in choosing the right place. One of the reasons that I chose to stay was because people don't leave. People typically get this job and then they retire from it. We've had a few people who had to move, but it was more for family and personal reasons. But job satisfaction wise, the majority of people, if not everyone, retires at the job here. So be sure that you're choosing to be a doctor for the right reasons. Be very careful in choosing the right job that fits you, fits your practice. There's going to be jobs that pay a lot of money, but with paying a lot of money, there's sacrifices that comes with that. There's significant time away from family. You have to be okay with that. You have to be okay with making that sacrifice. I had a friend, and he did it the right way, where he went and took probably one of the highest paying jobs as a cardiologist that doesn't put in stents, but knowing that it was his short-term goal. He did that for about 2 years, maybe 3 years, moved back to his hometown, got married, settled down, has 2 kids, doing well, loves his job. And if you have the luxury of being able to do that before you start a family, do that. But if you already have a family like I did when I started cardiology, I wanted to make sure that the job that I chose was going to be one that I can see myself working for the rest of my life. And I have no regrets with that. In the next video, or next scene, I'm gonna show you what my schedule looks like for January. Hashtag, actually I'm not, because I think I already talked about it. My January is gonna be pretty crazy, but I understand that February and March and the rest of the year is gonna be a lot lighter. I'm probably gonna look at the rest of the 2025 to see areas that I can, take a step back and maybe take a 3-day weekend, or maybe even take a whole week to kind of reset and enjoy the fruits of my labor of hard work, but also labor of having 2 amazing kids that I can spend more time with. So my January to June is already set. So right now I'm going to be working on my July to December of 2025. All right, heading back to the office. I'm going to start seeing my first patient in about 10 to 15 minutes, and then have about 5 patients. We'll discuss all the cases that we see as they come. All right, so my first patient is here for a 1-year follow-up visit. Saw him for the first time, I guess this is going on year 2 for us. But I saw him January of last year, so January of this year. Just looking it up. Abnormal stress test. And then he had further cardiac evaluation that didn't show any blockage, but was still having a lot of symptoms, so we subsequently did a cardiac catheterization, which is a procedure that we use to look for blockages in the heart. We can use the artery in the wrist. We try to use that one. Sometimes we may have to use the artery in the groin. But overall, didn't look like he needed any stents. Was still having symptoms, so we did a sleep test on him, and he was diagnosed with sleep apnea. All of his symptoms basically resolved after utilizing CPAP, monitoring blood pressure, getting really good control of his blood pressure, and since then he's been doing good. So it's more or less a 1-year follow-up to make sure that he's still remaining good. As expected, he's doing really, really good. No chest pain, no shortness of breath. Overall, he had no complaints. His blood pressure is exactly where we want it to be. He actually brought me his readings. It's been ranging from 120s to 130s. So one of the biggest recommendations that we had for him is weight loss. Over the next year, my goal for him is 10%. So 20 to 30 pounds seems impossible sometimes, but if you break it down, that's 2 to 3 pounds per month. And just monitoring what you're eating and monitoring your consistency. He's aware of the areas that he needs to work on, so we just do that. But more importantly, we be consistent, because we can have really good days, but for him, we need to have really consistent weeks and months. And when, it's one of those things where it's a feedback. When he starts to lose weight, he'll look at more ways that he can potentially lose more weight. So always important to just stress this importance that, weight loss and our weight is probably one of the biggest risk factors when it comes to heart disease and our overall health. It's one of those things that we can potentially change and, prevent. I think it's second to smoking in preventable diseases. So he understands that, and I'm sad to say that he didn't want to see me for a while. So we're going to do a follow up in about 2 years. He's actually going to call me um, at that time. And if he's doing good, then he can just continue with his follow ups with his medical provider. So, as I expected, this individual had a CT scan of the chest for other reasons, and with that CT scan, they actually saw some calcium or plaque around the arteries, which prompted this office visit. Prior to this, they had cholesterol levels checked, and they were slightly elevated, and they had already started them on cholesterol medications, but also recommending the importance of lifestyle changes and weight loss and nutrition, monitoring how much animal products they're taking in. I'm not shooting for perfection. The biggest thing I'm going to do is just recheck cholesterol levels to see where they are at. More than likely, I'm not going to escalate therapies, more just focusing on lifestyle changes, looking at what you're eating, looking at some weight loss if they can, but also following up on any symptoms they may have that is different from their normal, such as shortness of breath or chest pain. Overall, this individual is doing extremely well to the point where I'm actually going to follow up with them in 1 year. But if they have any issues in between then they can come and see me and we can do further evaluations to see what's going on. Check labs, follow up on labs, and then just have them keep on living life, but keeping us informed if anything should change. So, palpitations is one of the most common reasons why someone comes and sees me. So, what exactly could be causing your palpitations? For this individual that I just saw, it was for something called SVT or supraventricular tachycardia. So, when someone is having palpitations, how do we first work them up? The first thing is going to be an EKG just to see what your rhythm looks like right now. A lot of times this won't capture your palpitations, especially if it's not happening as frequently. For those individuals, we can do something like a heart monitor. It can be as that monitors your heart continuously 24/7. You do wear it on your chest. It can be as little as 24 hours, but can go as long as 30 days. If that doesn't capture it, then for some people, they may actually benefit from a loop recorder, which is basically a heart monitor that is implanted under the skin. The benefit of this is that it can last anywhere from 2 to 3 years, sometimes even longer, so you can monitor it continuously. I don't use that often. The biggest reason why I would use it is for someone who's having multiple strokes, but we haven't been able to find the cause, specifically atrial fibrillation, which is an abnormal rhythm that comes from the top part of the heart, but has the risk of strokes. So there's a lot of different things that we can use for palpitations to uncover the reasons for it. A lot of times people have it, but their monitors are normal. Monitors are negative, but it starts with getting an EKG monitor, sometimes even a loop recorder. There are many medications that we can utilize for it, such as beta blockers. Some people may even need an ablation. We also have to look at risk factors for it, underlying heart disease, heart failure, but issues with electrolytes, potassium, magnesium can be all big causes of it. Sleep apnea can be a huge cause of it. So in addition to treating it with medications, we have to also look at the risk factors for it to potentially treat that and prevent it from occurring as frequently. My individual that I'm seeing, my patient that I'm seeing, thankfully hers has been well controlled with her current medical therapies, and um, I've given the recommendation that if she starts having more and more symptoms, that we can do a heart monitor to see how often it's happening, basically to see if they need to have an ablation done, and we can start that process with having her see one of my partners who specializes in it. So today almost feels like it was palpitations, heart rhythm day, because that's been, let me see if I can get that. There you go. Um, because that's been the majority of the patients that I've been seeing is for palpitations and heart rhythms. This next one is for something called inappropriate sinus tachycardia, which is pretty interesting. Like the word says, it's sinus tachycardia, which is an elevated heart rate. This is what your heart is when your heart rate is when you're working out, when you're running, when you're stressed. But theirs is doing it inappropriately. It's basically always fast, a little bit over 100 at baseline. So we utilize medications for it, beta blockers, looking at electrolytes. All of hers has been normal, but she didn't tolerate beta blockers well. She did tolerate a medication called ivabradine, but she only tolerates the brand version, and of course pharmacy is now using the generic version. So I'm trying my best to get her back on the brand version and following up on her symptoms. If that pharmacy doesn't have it, then we may have to look at other pharmacies around the area, nearby pharmacies that carry it, because she just does really well with the brand version. And this happens to a lot of patients too, where generic versions work for a lot, but there are some people who just can't tolerate the generic versions and needs the brand versions. Unfortunately, pharmacies try to save some coins by using the generic versions predominantly. So it's now up to us to kind of look for the best pharmacy for her. And it may mean going to a new one, to a different one, getting seen and treated there. Hopefully, with a phone call, we can get her back on the brand version of it. If we get her back on the brand version, when we get her back on the brand version, if she's still having symptoms, then we may need to do a heart monitor to make sure that she's not developing any other rhythms or arrhythmias that can be causing her sensation of not feeling so well. So I just finished seeing my last patient, and if you can guess what I saw them for, you'd be somewhat correct. It was for heart rhythm issues, so specifically atrial fibrillation. It's that one rhythm that can lead to stroke, so he's appropriately being treated for that with a blood thinner. He's just been having episodes where he goes in and out of atrial fibrillation, so that's known as paroxysmal atrial fibrillation, when you go in and out of it continuously. So last week, I believe, or the week prior to it, I actually shocked him back into normal rhythm, and this was a follow-up to make sure that he's still in rhythm, which he is. The biggest thing is, what can we do to, keep him in rhythm? He's on all the right medications. He's on a rhythm controlling medication. With his advanced age, sometimes that can be a risk factor. He was holding on to extra fluid, so we gave him medications to get rid of that extra fluid. So that could have been a reason why he went out of rhythm. So right now I'm rechecking labs to make sure his kidney numbers look good, and that marker of extra fluid, which is known as a BNP, has gone down. I do anticipate for it to be a little bit elevated because he has concomitant kidney issues. He's not following with a nephrologist, so that was one of my biggest recommendations, for him to start seeing one at least once, if not twice a year. So I'm going to put a referral for him to see a nephrologist, and then follow up on his labs. Tomorrow's a weekend, so I'll be getting his labs probably on Monday, and I'll give my phone call at that time.